So this one has a front-loading dose for a patient that's high risk. If they're, but not to be used if they're over 75 or they have severe liver disease, that you give them the Librium 50 milligrams every 4 hours for 3 doses. And if they're 60 to 75, you give them a lower dose, 25 Q4 for 3 doses. And then like I said, I really like the way it talks about the CWAS score and how often you have to assess that patient. So if they have low CWAS scores, they're doing well. You only have to look at them every 4 hours, which you guys probably go in there every hour to see your patients, but you won't have to do the full assessment. But if they're high, you have to do them more often. So I like the way that's logically written out for the nurse. And then you can also use the Ativan in a patient that needs IV, or, because a lot of our patients, the only reason I like to admit these patients that come all the time is if they truly have a medical need, like their potassium is 1, and they have an arrhythmia, they're vomiting blood, or they're vomiting, or they can't walk. I mean, we have some patients that they can't go home because they just can't walk because their potassium's so low and they're feeling so poorly. So there's a second order set for the patient that's high risk for seizures, and that it's real easy on there, and the physicians will be filling it out. I took these right from Epic, so they should work right well when we switch in February.
So I just want to clarify, because I actually didn't see that one go forward.
Oh, you didn't see that one?
No, go forward. So
Okay.
I'll look for that to make sure that
Can you look for it? It's short.
Okay.
Because I just chose the one anti-seizure medicine.
Yeah.
And it's easy.
Okay.
Pretty much the nurse doesn't have to do a whole lot except to give the medication. And you just give it for the time that they're in the hospital, and you don't send them home on it generally.
Okay.
So it's just a prevention treatment in the hospital. What questions do you guys have? I know I talked really fast. I expected it to take me forever to go through those slides.
And so for the high seizures, is it just past history of, is that a risk, or how would you know?
They tell you. I had a seizure when I had withdrawal in 1985 when I tried to quit drinking. Now sometimes they say that just because they know it'll get them admitted. But like that patient that came to the ER and had a seizure in the jail and ended up with a subdural. Yeah. I know the surgery section was asking us, why didn't we admit that patient? And I just didn't feel like the patient met inpatient criteria. But maybe, certainly the second time, maybe he did because we knew he had a seizure the first time.
Was he admitted the second time? I remember
he did. He got admitted twice, and both times he had head trauma from seizures. I think he had both times been forced to abstain by jail. And mostly because he's an alcoholic. I don't think he was doing a lot of other bad things. He just kept getting arrested for DUIs and drunken and disorderly conduct kind of stuff. But, I always feel like I don't want to admit those patients unless they're really going to stop drinking. Because sometimes you feel like you're doing nothing when you're taking care of patients. Yeah. I'm sure you guys feel that way too.
Well, especially if they're
just going to go and drink
every 6 months or whatever.
Or every 2 months, every 2 weeks, some of them. Yeah.
Well, I just had a question too about, because I don't know very well about the prison system. Do they have medical detox in the prison?
No.
Or do they? Okay.
So if they act, they bring them over to us if they act like they're going into withdrawal.
Okay.
And I think that patient more was just intoxicated and they brought him over, not when he was withdrawing. If they would have brought us to him when he was shaky and weak before the seizure, that would have helped. And maybe we need to educate them too. Those are the patients they probably should go ahead and bring over. I mean, what happens, honestly, is they do not want to pay to have them in the hospital, because what happens is if they arrest me and I'm an alcoholic and I start withdrawing and they bring me to the hospital and I get admitted, they have to pay the bill. So they don't like that. And a lot of times what will happen though is they'll bring them over with chest pain or with withdrawal, and they just let them out of jail. But that is part of the problem and part of the disincentive for them to bring those patients to us. And I don't know, maybe there needs to be a better way.
Are they considered arrested if they just bring them to the hospital for care? And then
it depends, Susan. I mean, there's some they just pick up because they're laying on the floor and they bring them in, and there's some who are arrested and they bring in because they're intoxicated.
Yeah, I think that.
And maybe we need to be educated about when do they bring them, and we can give them feedback about when they should bring them.
It's hard though for people to guess,
It is hard in there, you know,
I
it's
mean,
when
they're
you're in
cheaters,
jail or,
you know.
and probably, the other thing is, I see it all the time, chest pain, chest pain, chest pain. So if you get arrested, tell me you have chest pain. They'll bring you to the ER and then they'll leave you. I shouldn't tell you that, but you know what I mean? I see that all the time, and a lot of it, they're just faking. It makes it hard to. Any other questions? Yeah.
Have you ever prescribed alcohol to help, like as a prophylaxis for
Yes.
some of these?
You know, in the past, we did that fairly frequently. I haven't in the last 6 or 8 months, but St. James will buy beer for patients. Like, if I come for a total knee repair and it's clear I'm never going to quit drinking, of course, maybe those patients shouldn't have a total knee repair, but say if I came for an acute appendicitis, although they're NPO, but you know what I mean. Some of the patients came for pneumonia, maybe, and it's clear they're not going to quit drinking, and they tell you, I am not going to quit drinking. Alcohol is the most effective prevention for DTs. And I don't know if other hospitals do it, but since I've been here for the 16 or 15 years at St. James, we do it sometimes if the patient is clearly not going to quit. Or if they get admitted because their sodium is 105 and they're clearly not going to quit drinking, I usually will give them 3 beers a day. Now that's not going to prevent withdrawal because they usually drink 20, but it'll prevent it a little bit and help them kind of maybe cut down. At least that's how I think of it. Have you guys ever seen that at other places? Has anybody been in other places?
Yeah.
It does make sense. I mean, we used to do alcohol drips as well, and those have gone out of favor. And the patient, the only time I think you ever use those now is if someone has ethylene glycol poisoning.
Yeah.
But we used to use them just for the agitated alcoholic. But I don't think we've used them since I've been here in the 90s.
Not even anymore for ethylene glycol.
Yeah, they use dialysis or.
No, we have to set a date. We haven't done it.
You're right. There's other treatments now.
Yeah. But
So
they
I don't
didn't
think
have those
alcohol
before.
drips are probably all anymore.
Yeah. But what I don't understand is if somebody normally has a blood alcohol level, if they seem normal at 0.3.
Isn't that amazing? I can talk to you like
How do
normal.
they, and then they need up to like, I don't even understand quite how they live.
It's
with-
just
How do you
like the
afford it?
diabetics that are.
What is it?
The diabetics that are used to doing it.
Their neurons are
blood
just
sugars.
different.
Is it this?
And then,
And some people can drink 1 beer and get intoxicated, and some people it needs 10. So, like you don't see a ton of Japanese that are alcoholics because their liver doesn't metabolize alcohol well,
Alcohol
and
dehydrogenation.
1 drink will make them drunk. Whereas, you know, the Irish typically, they can handle alcohol really well. The general rule is 1 drink per hour. You can metabolize. If you drink more than that, you'll be drunk. But the general rule for most people, maybe not me, maybe not a slim person, or somebody that doesn't metabolize well, is 1 drink per hour. So anyway, it is fascinating how some people handle their alcohol, and it's amazing that even at 0.5, you'll go talk to that patient and they seem okay. It shocks me that their brain is that adapted. But obviously they're super high risk to get into serious trouble. And you know, the other problem, a lot of these patients are just so severely malnourished. They have just horrible problems from being malnourished all the years of drinking. Any other questions? So hopefully the new orders will work for you guys. I'm not a nurse, so I don't really know. But now they'll be calling me saying, Brett, this patient has a CWAS score of 12, and I'll know what you're talking about. Because I wouldn't have known before. It makes sense, though, that I should know what you're doing. And those, you guys in the past used to keep those alcohol withdrawal sheets on the door. Where are they now? In the computer?
Yeah.
Okay. I know Susan was telling me, though, that it isn't a perfect CWA. Because if I go to the computer now and I want to look and see what the scores have been, where do I find it? Does anybody know?
Under nursing, it's under special assessments.
Okay. I mean, one thing that I find with Centricity, and I hope Epic is better, is a lot of times if I want to find something, like whether you gave the person nitro, I just have to ask. And you hope that the night nurse told the day nurse, because it's hard sometimes to find in the system, but hopefully Epic will be better for us. But you know, that was the nice day where you could just look at a sheet and you knew what the score was. Any other questions? So thank you guys for coming on your day. It's off, and I know everyone's busy, so thank you very much. Hopefully they'll work well. Thanks.
Thank you.
I just want to say, if there was anyone in the ICU interested in working on some of the ICU order sets down the line when we get into Epic, because I think we will have the ability to kind of differentiate Monday, let me know, just send me an email, because we'll be looking.
I don't think anybody in here works in ICU.
But we'll have to recruit.
Yeah.
Yeah.
I've got certificates for everybody before you go.
Mary.
Do you want to pick them up over there?
It's hard to do that, but also fast.
You do talk fast, I do, and the more nervous I get, the faster I talk.
I do that too.
Yeah.
Can do an hour and a half talking.
It should have taken me an hour.